So now it's on live, ma'am.
Yeah.
Yeah, ma'am, we are starting. So very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare. Welcoming you all for today's webinar. So the topic for today's webinar is ovarian stimulation protocols, and I welcome all the participants, and I request them to post their queries in the comment box so that we can have a short Q&A session at the end of this presentation. And now it's time to introduce our invited speaker for the day, Dr. Alka. Madam has completed the MBBS, DGU and DNB, and Madam is currently the director at Alka IVF Shri Kanak Hospital, Udaipur, Rajasthan. And Madam has more than 15 years of experience in the field. And with this short introduction, I welcome you, ma'am, and I'm handing the session to you.
Thank you so much. Yeah. I'll take the mic right now and I'll start with my presentation. I'm not very clear who all are delegates right now, but I will try to keep this session which will be useful for the practitioners who are practicing infertility, as well as the new aspirants who want to be infertility specialists later on, or the senior residents who have finished their post-graduation and they are pursuing a senior residency, or they wish to be infertility specialists in their lives. So the first question what we need to answer, just a minute, this slide, right? Why do we need controlled ovarian hyperstimulation? There are two reasons. That first is to develop multiple ovarian follicles to get multiple oocytes. So the question is this: why do we want multiple oocytes? That needs to be answered. Actually, there were many debates that how many oocytes are required for a good outcome in IVF cycles. There were a lot of differences in opinion. So there was a conference in Vienna, and after an expert meeting, there were few indicators fixed which will assess the performance of an IRT laboratory, and those indicators will help us decide about our stimulation protocols and how many follicles are going to be helpful. That will be helped by this. So those performance indicators, there is something called benchmark value. Benchmark value means this is the target thing which we must achieve. There is something called proportion of oocytes recovered, means whatever follicles we are able to see on the ultrasound during a stimulation cycle, all of them are not going to get retrieved when we are performing an ovum pickup procedures. So if we are able to get around 80 to 95% of the follicles, then it is a good benchmark value what we have achieved. And similarly, out of how many follicles we have aspirated and how many oocytes we have retrieved, out of them how many are M2 oocytes, because that these are the only oocytes which will be useful for ICSI. So that needs to be calculated by number of oocytes retrieved, M2 retrieved out of the total oocytes retrieved. And if we are able to get around 75 to 90%, then we are touching the benchmark value. So like this, there are many key performance indicators which we need to achieve. There is something called competency value and there is something benchmark value. So if you are able to reach up to the competence value, then also it is a satisfactory thing, but we have to ultimately achieve the benchmark value. And I am going to very briefly take this thing, because if we go into details of everything, every calculation which is displaying on the screen, then it will take a lot of time. But the important thing what we need to understand is these four things, that all the follicles which are visible on the ultrasound are not going to yield you the mature oocytes, and out of the total oocytes retrieved, how many are M2 oocytes. And if we perform ICSI on mature oocytes, M2 oocytes, all of them are not going to get fertilized, and all whatever oocytes, number of oocytes we have fertilized will not turn into blastocysts. This we will understand using a very simple calculation, which I will start with this slide. That suppose on ultrasound we are able to see 15 follicles. Out of this 15 follicles, when we are going to do a ovum pickup, only 13.5 oocytes are going to we are going to retrieve, and this is a very win-win situation when we are getting 90% of the follicles we are aspirating and leading them to and those follicles are yielding the oocytes to us. Out of these 13.5 oocytes, if we have 75% M2 oocytes out of them, then we land up having 10 M2 oocytes. Out of these 10 M2 oocytes, if we do ICSI and we have a 75% of fertilization rate, then we have 7.5 fertilized oocytes. Out of this, if we have 60% day 3 embryo conversion rate, then we have only 4.5 day 3 embryos. And if we have a good blastocyst conversion, then we land up 3.5 blastocysts. And out of that, if we want to grade those blastocysts, and if we want top quality blastocysts, grade 1 blastocysts, then out of these 3.5 total blastocysts which we have achieved after having 15 follicles on ultrasound, we have only 2 to 2.5 top quality blastocysts. So what I want to say, that if we begin with 15 follicles seen on ultrasound, ultimately we land up having 2.5 top quality blastocysts, means 2 to 3 blastocysts only we are able to get that are also good quality. And if we correlate these good quality blastocysts with the euploid blastocyst, if we take it 50% blastocysts are euploid, then only we land up having 1 to 2 euploid blastocysts at the end when we begin with 15 follicles. And out of these embryo transfers with euploid blastocyst, around how many will be the pregnancy and live birth rate? So that is a very important slide. I would like all of you to give some attention, that ART procedure is not that if we see very good follicles, so that guarantees us a very good blastocyst or a pregnancy later on. So the aim of controlled ovarian hyperstimulation should be very clear to us, that this is the reason why we want multiple oocytes. And the second aim is to prevent premature LH surge. These are the two aims of COH. Why we want to, first question is already answered, that why we want multiple oocytes. Now the second question needs to be answered, why premature LH surge is bad for us. Because it disrupts oocyte maturation, it disrupts its competence, quality of fertilization, and later on the receptivity and the pregnancy rates are very low if there is premature LH surge. So these two things we need to take care when we are addressing controlled ovarian hyperstimulation. Then if we have started a patient, what are the things we have to keep in our mind? That if we are doing a ovarian stimulation, it should be safe, it should be effective means the maximum number of oocytes possible should be retrieved so that we land up having good blastocyst, and it should be patient centric. I mean, it should decrease the time to pregnancy, and ideal ovarian stimulation regime for IVF should have low cancellation rate, minimum drug cost, minimum risk and side effects. It should require very limited monitoring, and it should maximize, I stress, singleton pregnancy, not multiple pregnancies. So this ideal ovarian stimulation regime, so far we are not able to find, but we are daily growing in this aspect, in this particular field of gynecology, and shortly we'll be able to definitely address few more questions over years. Now we will talk about these are the 5 to 6 points I'm going to discuss today, that how the ovarian stimulation has evolved in the past few years. Just give me a minute. So the key points, that what are the ovarian reserve markers we are using nowadays, and what are the good drugs, and what are all the stimulation protocols are available, and out of them how do we categorize which protocol to be needs to be used for which category of patients. And a very, very important question which needs to be clarified to many of us, that when and to whom we have to do LH supplementation, so that we integrate strategies to maximize beneficial effects of the treatment and minimize risk and complications of the ART procedures. So to understand this, I will very, very shortly in 2 to 3 slides cover up the endocrinology of ART cycle, not the normal menstrual cycle. I am stressing on the ART cycle only. This slide, we are able to see there is a dotted line which is showing the FSH concentration. This FSH plasma level is called the threshold level, which needs to be attained for a follicle to keep growing. Why this is important? Because during a menstrual cycle, how God or the nature has created that only one follicle will be growing, the rest will go atretic, because whatever the FSH concentrations are there in the early follicular phase. So out of many follicles which have started growing, only one follicle will have so many FSH receptors that that particular follicle will be able to compete with other follicles to achieve that FSH threshold plasma level, and only that follicle will be able to grow. Rest will go for atresia, and this is called FSH threshold level. This level needs to be surpassed to keep a follicle growing. Otherwise, if the FSH threshold hasn't been achieved, that follicle will not be able to grow. It will go for atresia. This slide will help you understanding this, that this first graph is showing a natural cycle, and that window, FSH window, is open only for a very small period of time, and during this period that FSH threshold is being crossed, and only that follicle will grow, rest all will go atretic. And what do we do in conventional stimulated cycle? We don't allow this FSH concentration to fall down. We will keep giving FSH, exogenous FSH, so that this FSH threshold is not falling, and whatever number of follicles are there, they will all keep growing, and we get multiple follicular recruitment. The third graph is showing mildly stimulated cycle, where we do increase the FSH window, but it will be extended compared to the normal cycle, but not as as much extended as to the conventional stimulated cycle, so that the follicles are retrieved, but the number of follicles are comparatively less than the conventional stimulated cycle. Then one more important thing is LH ceiling hypothesis. This all we have read that LH levels are good between 1 to 5 international units. If we have very high LH levels, they are also not good. Very low, they are also not good. What is the role of LH? We all understand two cell, two gonadotropin theory, that there are theca cells and granulosa cells. During the early follicular phase, the LH will act on theca cells and it will help in steroidogenesis, and later on the same LH will act on granulosa cell and it will lead the final follicular maturation, what we see during the LH surge. And for successful stimulation regime, there are few requisites which we are able to fulfill, like FSH window. How do we increase that the time? By giving exogenous gonadotropins. How do we prevent premature LS surge? Either by giving GnRH agonist or antagonist. Follicular or oocyte maturation, how do we achieve that? By exogenous HCG, that is the trigger. And now if the agonist trigger is becoming more and more popular nowadays, so along with HCG we can replace HCG with GnRH agonist trigger, and the luteal support is with exogenous progesterone. So this is how we have understood the multifollicular recruitment, how it happens in a stimulated cycle. Now, various regimes are there. I'm not going to deal with all of them because today, if I start discussing with the clomiphene citrate or letrozole in details, it will take, it will deviate us from the ART cycles. There are these kind of stimulation regimes where we just follow a natural cycle. There is no stimulation at all. And mild stimulation, minimal stimulation, and aggressive stimulation. And I'm not taking these things in detail. Yes, but clomiphene citrate, we need to understand because this medicine is being used for, decades now. A lot of data is available, a lot of, experience with this drug. In between, aromatase inhibitor letrozole took over this drug, but again, it defeated letrozole and came back with a boom again in the market that letrozole is, but there are a lot of studies going on now. There was a time when we favored letrozole because clomiphene was doing multifollicular recruitment and multiple pregnancies were high. The side effects were there with clomiphene. But again, it has come to the market, and we have to understand the mechanism of action of clomiphene, because not every category of patient can be prescribed clomiphene. It's a centrally acting. It is an selective estrogen receptor modulator. It blocks the estrogen receptors at the level of pituitary, so that that increased estrogen, which prevents FSH release from the pituitary, is not inhibited. Increased FSH concentration from the pituitary acting on ovary will allow growth of a follicle, and even up to 4-5 follicles can grow if the patient is a good responder on clomiphene. And these multiple follicular recruitment is the side effect or the not very welcome effect of a clomiphene cycle. So the ideal candidate for CC stimulation regime is a WHO group 2 patient, wherein this is called normogonadotropic patient. Mostly the PCOS patients fall into this category. Who is not a candidate for a CC stimulation regime is a group 1, where there is a failure in hypothalamus or pituitary, because we have just understood the mechanism of action that clomiphene citrate will act centrally at the level of hypothalamus pituitary, and a woman with hypothalamic amenorrhea related to stress, weight loss, exercise, anorexia, Kalman syndrome, these are not the females who should be given clomiphene. And there are multiple regimes which are possible, but in short we will just understand that we can start CC any day from third to fifth day of cycle, and dosages are there. The books are recommending up to 200, 250, but practically speaking, if a lady hasn't responded up to 150 milligram, then it's better that either we do some we add some adjutant to that clomiphene, or we should switch over to the injectable gonadotropins rather than just keeping the dose of clomiphene increasing. This is a slide which will help you understand how we have to use clomiphene. Again, it is showing that it can be started any day from second to fifth, and we need to do ultrasound after around 5 days of the last dose. This we have to understand. And then coming to letrozole, this is again very commonly used in a PCO patient because it helps recruiting only one follicle. This is a slide showing how letrozole or aromatase inhibitor works, but I'm not going in details with this. Coming to minimal stimulation, which is becoming popular nowadays because it is less heavy on patient's pocket. A patient is given clomiphene citrate along with the gonadotropins. Generally used dose is I have written GF because I have personally used this product a lot. I have used other recombinant FSH also. They're all, good companies are providing it very nicely. So we can use any brand with what we want, but the dosages should be around 150 for recombinant FSH. And we add antagonist once the lead follicle has achieved 12 to 14 millimeter size. And then we trigger once the follicle is around 20 millimeter. These are the minimal stimulation protocol. We can just summarize the protocol in this slide, that we are using recombinant FSH along with clomiphene citrate. People have used half the dose of Cetro. Generally, we are using 0.25, but here we can use even 0.125 Cetro. And this is, very individual decision, because I personally just use CC along with gonalep without any antagonist. Then also the cycles are very nicely regulated. There is no premature LH surge, and we are monitoring the cycles on ultrasound, and we trigger once the maximum cohort is between 18 to 20 millimeter of size. And after giving the trigger, we do the ovum pickup like in any other standard cycle after 36 hours of the trigger. And in minimum stimulation protocol also, we can use GnRH agonist as the trigger. These are the IVF light protocols where we can use Minopur also, the HMG, purified HMG also along with CC. This was, I was just discussing very briefly. Now my main stay was on gonadotropins usage during controlled ovarian hyperstimulations in ART procedures. There are battery of gonadotropins available, but to summarize, over years, when the IVF just came in the market, the gonadotropins which were available in 1931 started in 1931, they started with the animals, then they started with the menopausal urine, and over years, the gonadotropins have gone extensive research, and nowadays we are using recombinant human FSH, and we are having recombinant human LH also, which are filled by masses, so that the batch to batch variability is very, very less. And nowadays we are having very nicely patient friendly recombinant FSH pens also, so that the patient doesn't need to travel to the hospital also daily. They can just be very easily explained by the nursing staff how that those pens can be used, so that self administration is also possible if the patient is ready, and is the patient is able is patient is able to do self administration of these drugs. If you can educate your patient to that level, then we can use those pens also. So these are the uh, uh, latest gonadotropins available with us. Coming to this question, that when do we need exogenous gonadotropins? First is hypogonadism. I mean, if the hypothalamus or pituitary is not working, then these aromatase inhibitors or clomiphene citrate, they will not help, because they both act at that level of hypothalamus pituitary axis. Or if we have given clomiphene to a patient but it is resistant, clomiphene resistance is like the patient is not responding to the clomiphene, then we have to use these exogenous gonadotropins, or in case of unexplained infertility, we should be using gonadotropins. There are multiple regimes available, like step up regime, which I will, as the name is suggesting, that we are stepping up the gonadotropins. Stepping up means we are starting with the low dose, but gradually we are increasing the dose of the gonadotropins. This is particularly useful in cases of PCOS, where we don't want multiple follicular recruitment, and we need only one or two follicles, or at most three follicles to be recruited if we are doing ovulation induction. I'm not talking about IVF cycles. I'm talking about the ovulation induction cycle, where this step up regime is useful for a PCO patient. Similarly, there is step down regime. And this is a example I have kept in a flow chart, how a step up protocol is used. If somebody is interested, they can just get in my personal touch, and we can discuss this, where the step up and how the step up protocol needs to be used. This is a step down regime, that the initial few 4 to 5 days is we are giving higher dosages, and gradually we are decreasing the dose later on. And this is an example of step down regime, where we have shortly, if we discuss, that we have started the dose of 150 to 250 international units for 5 days. We do an ultrasonography if the follicles have achieved more than 9 millimeters, because this is the time when we this is the time when we take it, okay, this follicle has been recruited, more than 9 to 10 millimeter is the size. When we understand that this is the dominant follicle, once we have achieved this size, then we can decrease the dose to 37.5, or we can that depends how much we have started. If we have started with 250, immediately we cannot decrease it up to 100 or 150. This is the value we should reduce from the initial starting dose of the gonadotropin. If there is no follicle, then we increase this dose, whatever we have started with. Suppose we have started with 150, then 150 plus 137, 187.5 will increase, and we maintain that dose. If we get more than 9 millimeter, we follow this. If we still don't get it, then we need to cancel this cycle in a step down regime. And these two approaches can also be combined in the sense that initially we increase the dose, we start with a very high dose, but then later on we can just decrease the dose. Once we get the dominant follicle, we can decrease the dose. Coming to this, I have covered one set of questions that why do we need multiple follicles? What are the KPIs? How many follicles we must be having so that we, are able to clearly identify who are the poor responders, normal responders, hyper responders. Then we discussed clomiphene, aromatase inhibitors, gonadotropins for ovulation induction. What is the step-up protocol, step-down protocol, long dose protocol? And now we have to answer the second question, that how to prevent the premature LH surge. So there are GnRH analogs, which can be a agonist or a antagonist. This is a very favorite slide of mine. We must understand if we are choosing a GnRH agonist protocol or an antagonist protocol, what is the basic difference in the agonist and antagonist. I think we need to, just remember these 5 points, that what is the mechanism of action in case of GnRH agonist and antagonist, that this down regulates the pituitary. Means there is internalization of the FSH receptor at the level of pituitary, so that there is no more FSH which is possibly released from the ovary. So the whole body is dependent on whatever exogenous FSH we are providing. In this case, GnRH will go and occupy those FSH receptors on the pituitary. So they are competitive inhibitors of the receptor. How many days it takes for a GnRH antagonist to show its effect is 7 to 10 days. Means when initially we start using GnRH agonist for 3 to 4 days, instead of decreasing the LH, it will do a flare effect. It will increase release of both FSH and LH. After around 7 to 10 days, pituitary will be down regulated. There will be no more receptors available on the pituitary surface, and there are no more FSH or LH released. While in GnRH antagonist, immediately, means after 2 hours of injection, this antagonist will start acting. In GnRH agonist protocol, when do we start treatment? In the luteal phase of the previous cycle. There is a treatment cycle when we have started the gonadotropins, but in GnRH agonist cycle, we will start the agonist, GnRH agonist, from the luteal phase of the previous cycle. And in antagonist cycle, we will start them from this particular treatment cycle, because their duration of action is same for both, but there are depot preparations available for antagonists. So far, for agonists, for antagonists, there are no depot preparations available. These are the few examples of agonists and antagonists: leuprolide, triptorelin, gosaralin, which we have already studied in our post graduations. But to put to everybody's notice, this is the red color is the GnRH agonist protocol and blue is the GnRH antagonist protocol. When I started doing my infertility practice, I myself have used a lot of GnRH agonist protocol. But now, as we are able to see that when the in 2000s, when ART procedures were very new to people, almost 85% of the cycles were GnRH agonist cycle and only 14% were the GnRH antagonist cycles. And now, as the experience with GnRH antagonist protocols has improved day by day, the agonist protocol is falling with every particular passing year. And honestly speaking, after 2015, I have hardly used agonist protocol for very selected group of patients. I'm very happily using antagonist protocol for most of my patients. So GnRH agonist we have just understood the mechanism of action of GnRH agonist. They are commonly used because they are very, patient-friendly. Subcutaneous injections, absolutely painless, with a very small, tiny little needle, and we can use intranasal spray also. And these are the various regime which we can, just cannot stop discussing. Ultra short, long follicular, long luteal, many, protocols are available, but I'm not going to discuss them every protocol in detail today. But yes, one protocol we all must understand as infertility practitioners, that is long protocol, which is a gold standard protocol, which was a gold standard protocol, I would say, previously. But it lost its popularity because it wasn't a very patient-friendly protocol. It increased the treatment duration too much. There were multiple injections, and the patient had to visit to the hospital very frequently. And uh, it had prolonged the cycle duration very much, and the the dreaded complication which all gynecologists and infertility specialists are scared of is ovarian hyperstimulation syndrome, which was found to very high in long agonist cycles. And to understand this, I'm just showing this chart. Whatever is written here can be very much understood easily with this, that we start the leuprolide acetate in the previous menstrual cycle, day 21. That's why it is written day -7. In the previous menstrual cycle, we will start at the dose of 1 milligram per day. Then we have a menstrual cycle, and from day 2 or day 3 of the periods, or at least from 7 to 10 days after starting the leuprolide acetate, once the pituitary down regulated, then we start the gonadotropins. This is just written FSH HMG because we can use menotropins also, and we can use recombinant FSH also. And at the beginning, when the pituitary is down regulated, we can decrease the dose from 1 milligram to 0.5 milligram. And once the dominant follicle, I mean more than 3 to 4 follicles, or we can say the maximum cohort has achieved a good size around 18 to 20 millimeters, that is the time we give HCG trigger. We do a retrieval, and depending on your blastocyst transfer or day 3 day 4 day to day 3 transfers, we can do the transfer in the same cycle, and we are doing the progesterone support. So this is the summary of the long protocol. This is a pictorial depiction of whatever I have just narrated. And there are short or flare protocols which I haven't used in past 5-6 years now. I have been using antagonist protocols. These protocols were initially advocated for poor responders, but now antagonist protocols are much better than these protocols. Understanding the GnRH antagonists, we have understood that cetrorelix, ganirelix has been investigated the most, and we are using cetrorelix very commonly. I have personally used cetro only, and we are doing multiple daily dosaging, and the dosage is 0.25 milligram when we are doing daily dosaging. Now antagonist of 3 milligram depot, this is the depot antagonist, we can say, which is effective for 3 to 4 days. We are getting this 3 milligram injection also. And antagonist can be two different kind of protocols available in antagonist is fixed protocol or flexible protocol. This we will discuss what is a fixed protocol and flexible protocol. I would say that in GnRH agonist long protocol, we are starting the agonist right from the day 21 of the previous cycle. But when we are using antagonist protocol to prevent premature LH surge, we will add antagonist once the dominant follicle, I mean the lead follicle, is somewhere between 12 to 14 millimeters of size. That is the right time to add the antagonist. And this fixed and flexible, as the name is suggested, is suggesting us that fixed is like we have fixed ourselves that okay, from stimulation day 6 I will add antagonist whatever may be the size of the dominant follicle or the lead follicle, we can say, not dominant follicle, I'm using the wrong word, I must say the lead follicle, because in antagonist protocols that all the follicles will not be of the same size, which is found in the agonist, long agonist protocol. There will definitely be some discrepancy in the antagonist protocol follicular size when we are doing the ultrasound. And when we have decided okay, we'll follow the flexible protocol, is that we haven't fixed a day of stimulation. It can be day 5, it can be day 7 or 8 also, when we start adding the antagonist, because we have decided that rather than the day of stimulation, we will add antagonist once the lead follicle has attained a size of 12 to 14 millimeters. So the what is the second lesson what we have just learned, that antagonist cycles have improved the flexibility, it has decreased the duration of the stimulation, and as well as along with the decrease in duration, it has decreased the total drug used, and it has diminished or almost eliminated the risk of severe life-threatening OHSS, because every ARD clinic should be a OHSS free clinic. So after using a GnRH antagonist protocol and using GnRH agonist as trigger, we have almost eliminated the risk of severe OHSS. There were times when I have seen, a patient having severe hyperstimulation where we are doing abdominal paracentesis, doing a ascitic tap, and the patient is admitted in ICU because she is having pleural effusion and she is having difficulty breathing. I have seen one death also because of the severe hyperstimulation, because the kidney went into shutdown. So GnRH antagonist along with the recombinant FSH, that is the most favorable protocol for all the infertility specialists nowadays, because it decreases OHSS, it is very simple to use, and lastly I will show few slides which will prove that it is equally effective as the GnRH agonist cycle. Initially there was a debate that uh, the results, I mean the pregnancy rates are higher in agonist cycles compared to the antagonist cycle. But now when we are coming to an era of freezing of blastocyst and doing transfers in the next cycle, there is beyond any doubt proven that agonist antagonist cycles are equally effective. And the best and the most important helping and lucrative benefit of antagonist cycles is that we can use GnRH agonist as trigger that eliminates the risk of OHSS, and we are having equivalent pregnancy rates. It is more physiological compared to the agonist cycle and decreases OHSS. Now, if we are new to the ART stimulation protocols, a very common question which I am asked, that what dose I must use to do a controlled ovarian hyperstimulation. Let me tell you all of you that we cannot use a one single dose that okay, I will start all my patients with this dose. There are a few criterias which we have to keep in our mind, and I personally, and books are also recommending this, that these three things, age, AMH and BMI, or antral follicle count we must say, are the most important markers which we should use deciding the dosages for a patient. So this is like a very nice example for ovarian stimulation. The question is, does one size fits all? Obviously the answer will be No, the one size doesn't fit all of them. What is very important in deciding dose is AFC or AMH. On my left side, AFC is mentioned that antral follicle count, if it is between 0 to 5, 10, 15, 20, and the other diagram is the other line bar is showing the AMH, which is 1, 2, 3, 4. So as the AMH or the antral follicle count increases, we expect that this particular patient will have a very high response. So AMH of anything between 2 to 4 is between, they are the expected normal responders. Anything below 2 is falling towards the poor response, and anything more than 4 can fall into a category of higher response patients. So one size doesn't fit all, and we need to pay attention to age, AMH, BMI, and antral follicle count to decide for the dosages. So that is what is mentioned in this slide also, that AFC can be a very, very good functional biomarker of ovary response. And there are many dose calculating charts are also available. So I will just take example what is mentioned in this chart. If we have an AFC of around 7 to 8, what we are able to see here, and the age of a patient is around 30 years, then if we join this line, it will show us the dosages we should be using. It is around 150 international units of gonadotropins. So this, it's written also down in this slide, the nomogram for calculation of the FSH starting dose based on age and AFC. There's an example of a 30-year-old woman with AFC of 16. The FSH starting dose is 161.5 international units per day. Similarly, these are the dose nomograms available. We all can have them. Now we have understood that which protocol I have to use, what dose I have to use. Just in 2 slides, I will cover up whether I should use HMG or I should use recombinant FSH. This is also a very, very common question asked by new persons. I think I'm extending my time a lot. So this is showing that if we are using HMG, we are landing up in using high gonadotropins. There was a Cochrane review which said that recombinant FSH is definitely better than purified, because this is showing that live birth in the fresh cycles and cumulative birth is best if we have 10 to 15 oocytes retrieved, and recombinant FSH is improving the oocyte yield. This is showing that recombinant FSH lower dosages per live birth is proven. Now to summarize, I would recommend that if you find there is a patient who is a higher responder, then the starting dosages can be 150 to 187, normal responders 225, poor responders 300. I have just mentioned who all can be categorized under poor, high, or normal responders depending on AMH or AFC. Now we have started our simulation. We have to understand whether the dosages, what I have decided is actually adequate for the patient or not. That can be evaluated using this FORT. I mean, how many out of antral follicles are becoming the pre-ovulatory follicles is FORT, follicle output rate. If there is a hyporesponse, means to begin with the patient was showing good follicles on the ultrasound, but after day 5 or 8 of stimulation, only few follicles have grown, rest all have not grown. These are the patients who are labeled as hyperresponders. How do we manage hyperresponse? There are two options. Either we increase the dose of FSH or we add LH. So this slide will prove that LH supplementation is better than increasing the dose of FSH. This is third lesson I would like to emphasize today, that who all are the candidates who should be supplemented with LH during stimulation is advanced female age, poor responders, slow or hyper responders, or if there are patients who have profound LH suppression after down regulation. How much LH is sufficient? 75 to 150 international units is sufficient. So again, this is the slide which was emphasizing that rather than increasing the dose of FSH, it's a good idea to add LH. And this is a forest diagram, which is very clearly, this diamond is falling on this side, is very clearly saying that increasing FSH is not a good idea in patients who are older than 35 years of age. Better would be adding some LH to FSH in these categories of patients. Actually, when I was new, and when I was not able to understand these forest plots, I was very scared looking at this. But now I find that it is a very, very simple thing to understand today. Because of shortage of time, I will just put one point, that this black diamond is a very important, this is the only thing which we should be paying attention to a forest plot. If it is falling on this side of the midline, then it is favoring this side. If this diamond is falling on this side, it is favoring this limb of the study. So these are the a few forest plots which I had just kept to emphasize that initially there was a lot of burden, not only financial but mental and physical inconvenience to the patient because of the repeated blood samplings during the IVF cycles, because we used to monitor a lot of hormonal status. But this forest plot is very clearly indicating that monitoring of stimulated cycles in ART, IVF and ICSI cycles, there is no change in clinical pregnancy per woman if we are just using the ultrasound for monitoring these cycles. Similarly, this diagram is also showing there is no change in the mean number of oocytes retrieved if we are using ultrasound for the monitoring. This is showing there is no change in the OHSS rate. Also, this forest plot also says that monitoring alone with the ultrasound is sufficient enough. And I will conclude today with this slide because it's a very, very important slide, comparing agonist and antagonist. Rest all is same, number of oocytes retrieved, number of clinical pregnancy rates, rest everything is same. But this is a forest plot which is showing that this diamond is clearly on this side of the line, which is favoring GnRH antagonist protocol when we have evaluated the OHSS risk. Means when we are scared about OHSS, and if we are using antagonist cycle, then we are diminishing the risk of OHSS. So take home messages are, we must individualize the patient to decide which protocol to be used, why we should use, what are the pros and cons of this selected protocol, and how do we individualize the dose of starting dose of gonadotropins, and lastly decide which trigger in cases of GnRH antagonist cycle. Because in GnRH agonist long protocols, we can only use HCG as trigger. We don't have an option of using GnRH agonist as a trigger. But in antagonist cycles, if we are using agonist trigger, we are diminishing the risk of OHSS almost to the negligible levels. Thank you so very much. I will conclude with this, and I hand over the podium to now the question answer
Thank you,
session
ma'am.
person.
Thank you, ma'am. Thank you very much for that wonderful presentation, ma'am. It was a very much in detail presentation, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am.
Pardon?
Uh, yeah, ma'am. If there is any queries, then I'll read it for you, ma'am. So I can see more compliments that the presentation was very good, ma'am.
I don't know how much participants have understood, because I felt that the presentation was quite long.
Yeah, ma'am. We are getting comments from Dr. Santosh Dangi that the presentation was very nice, and another Dr. Abhi Yadav has done as mentioned as thanks for the good advice, madam. So I don't find any questions rather, ma'am. I can see only the appreciations for this presentation, ma'am.
That means people haven't understood it because I was very bad at it.
No, ma'am. I can take it in a positive way that they have understood very well, ma'am. So there is no questions. Ma'am, I have personally a question like, ma'am, what about the role of these supplements, ma'am, in this IVF? Like even today I read an article like myoinositol is useful in this ovulation
PCOS
induction.
patients, right? Right.
Yeah, ma'am. And one more thing is N-acetylcysteine, ma'am. So
Yeah.
N-acetylcysteine is also is coming as a new adjuvant for this ovulation induction, ma'am. So what
Yes.
will be your comments on this?
Definitely, actually, when I passed MBBS, N-acetylcysteine was taught as a mucolytic agent. But now, as with the progress, we have understood that N-acetylcysteine is a good adjuvant in insulin sensitizer also. So, in PCOS patients particularly, when we are using clomiphene citrate, people were initially recommending metformin also. Now N-acetylcysteine is a very, very good adjuvant to clomiphene citrate in PCOS patients to
Yeah, ma'am.
correct the hormonal imbalances and as well as insulin sensitizer.
Yeah, ma'am. We do have a product called the Ovashield DS, ma'am. So in that we have clomiphene citrate with N-acetylcysteine, ma'am. So
Right. This
when
combination is very good for PCOS.
yeah, ma'am.
Especially for patients who are not responding to clomiphene alone. So those are the category of patients when we are using clomiphene along with NAC, it's a good idea.
Yeah, ma'am. It's working well, ma'am. Most of the doctors are saying that this combination is very
Yes,
well
it
working,
is.
ma'am.
Yes, it is.
Yeah, ma'am. Oh, and ma'am, I don't find any other questions, ma'am. So if you allow us, then we can end the webinar for today, ma'am. If there is any queries, then I will forward it you to your personal mail ID, ma'am.
Yeah, sure, ma'am.
Yeah, ma'am.
Thank you so much.
Thank you very much for being with us and sharing a wonderful session with us today, ma'am.
Thank you.
Yes. So on behalf of Shield Healthcare, I would like to thank all the participants for their active participation and listening. I will send you the participants list once it is ready, ma'am. Within 24 hours, I will send you the participants list also.
No problem. Thank you.
Yeah, thank you, ma'am. Thank you very much again.